So building on Dr. Becker's talk, I'd like to talk to you guys today about cerebral hypoxia, minimizing neurologic injury post-arrest, neurologic outcome post-arrest, and then neuroprognostication after cardiac arrest. So first we'll start by talking about cerebral hypoxia. So as Dr. Becker mentioned, oxygen is very important for the brain. There's a number of different types of situations in which there could be poor oxygen going to the brain. So one is called hypoxemic hypoxia, where somebody's not breathing a lot and there's poor oxygen going to the brain because they're not breathing appropriately. You could also have anemic hypoxia, where there's low levels of oxygen in the blood and you're losing blood and therefore there's not good oxygen going to the brain. You have histotoxic hypoxia, where there's chemicals in the body like carbon monoxide that's preventing oxygen from going to the brain. And then lastly, ischemic hypoxia, which is what we'll be focusing on today, which is where there's low oxygen delivery to the brain due to low blood flow going to the brain. Now, how does this work? Normally in the body, depending on what the blood pressure is, if the blood pressure is anywhere in a normal range, so anywhere between slightly low at 50, all the way up to slightly high at 150, inside the brain, the arterioles will regulate themselves to make sure that the blood flow that's going to the brain is the same amount. So that's called autoregulation. So the arterioles will be smaller or larger depending on what the blood pressure is to allow for good blood flow and good blood pressure going to the brain. However, when the blood pressure is extremely low or when the blood pressure is extremely high, the arterioles don't respond in a normal fashion, and as a result there could be too low blood flow going to the brain or too high blood flow going to the brain. The situation that we're talking about here today is when the blood pressure is extremely low, the arterioles don't respond appropriately, and as a result there's too low blood flow going to the brain, and that's less blood flow than the brain needs in order to respond normally, and so it responds in an ischemic state, leading to death of cells. What are the areas of the brain that are most vulnerable to hypoxia? So obviously the brain has a lot of different structures and is responsible for a lot of different things, but there are certain parts of the brain who are particularly vulnerable to hypoxia. So the cerebral cortex, which is responsible for cognition, for language, for movement, and for sensation, is one of the most vulnerable areas of the brain to hypoxia. Additionally, the hippocampus, which is responsible for memory, is extremely vulnerable to hypoxia. The basal ganglia, which is responsible for movement, is vulnerable to hypoxia. Lastly, the cerebellum and the thalamus are vulnerable to hypoxia. The cerebellum is involved in movement and balance, and the thalamus is responsible for communicating information from the top of the brain, the cortex, to the base of the brain stem, and the rest of the body. And therefore it's involved in consciousness, alertness, memory, movement, and sensation. So as you can see, parts of the brain that are responsible for many, many important actions of the body are vulnerable to hypoxia. So when is the time of injury after cardiac arrest? So as Dr. Becker mentioned, we're not just worried about the time of injury being at the moment when arrest happens. We actually worry about injury even further out from the time after cardiac arrest. So you can see here on this chart, the time of injury is not within just the first few hours after arrest, but rather we can see that injury can keep on occurring many days after arrest. So even after reperfusion has been established, there still can be ongoing injury to the brain. And this is as a result of two different processes. So first is the issue of what happens at the exact time of the arrest. So this is the ischemic hypoxia. So at the time of a hypoxic event, such as cardiac arrest, then there's poor blood flow going to the brain. As a result, the person will respond by losing consciousness because they're having poor blood flow going to the brain. Subsequently, there will be involvement of problems with the cells, including cellular acidosis, depletion of the ATP store. So ATP is what allows the cells to function in a normal fashion to allow energy to go in and out of cells. Additionally, what will next happen is cytokines. So negative types of factors will influence the cells, leading to depolarization of the neuronal membranes. Subsequently, there can be intracellular influx of sodium, chloride, water, and calcium, and this can then result in cellular swelling and then cellular death. So this is the first part of time when there's a problem with respect to the ischemic hypoxia. But the second issue is even after reperfusion has been established, after blood flow is returned to the brain, there still can be ongoing injury to the brain, and this can happen as a result of a different set of processes. So this is the result of edema, oxidative injury, and ongoing ischemia. So how can we help to minimize neurologic injury after cardiac arrest? So first, the most important thing at the time of the arrest is high quality CPR. So that was addressed previously. It's important to perform good CPR to improve blood flow going to the brain during the time of the arrest. And this is based on the good quality CPR is defined based upon the number of compressions done per minute and ensuring that additional measures are employed, such as the use of the defibrillator to reestablish blood flow. And then secondarily, there's a question of neuroprotective strategies, some of which were mentioned in the prior presentation regarding a cocktail that could be employed, and others which will be addressed later by Dr. Grossman. One thing which was brought up in the last presentation, which is really important to focus on, is therapeutic hypothermia, which can be employed in order to allow there to be improvement of brain resuscitation after cardiac arrest. So the purpose of therapeutic hypothermia, so cooling of the brain, allows the inhibition of the release of dopamine and glutamate, oxidative stress, and free radical reactions, all of which can cause damage to the brain cells. And there were 2 different studies that were done that we base our information on regarding the use of therapeutic hypothermia, both of which were published in 2002. And what these studies showed us, one which was conducted in Europe and one which was conducted in Australia, showed us that the use of hypothermia, so cooling down the brain, allowed for a better neurologic outcome and also decreased the risk of death after cardiac arrest. Now, as was also mentioned previously, there's different temperatures that potentially we should be cooling to, and we're not really sure. So previously in the initial trials, we cooled to 33, then another trial was done more recently looking at cooling to 36 degrees Celsius to try and see, is 36 better, is 33 better, or are they just the same? And what we found was that 36 degrees Celsius was non-inferior to 33 degrees Celsius, so it's no worse than 33 degrees Celsius. So what do we do with that information now? Well, different people do different things. So in general, we want to cool post-arrest, regardless of where an arrest has happened, regardless of whether it was in the hospital or out of the hospital, regardless of the type of cardiac rhythm that a person was in at the time of the arrest. However, in terms of the temperature to go to, that varies from hospital to hospital and sometimes varies based upon the rhythm that the person was in at the time of the arrest, though there's no specific science dictating that. Notably, in terms of when should we not cool post-arrest, so for somebody who was comatose and unresponsive prior to the time of the arrest, that could be a potential situation where it would be reasonable to consider that potentially the risks of cooling could potentially outweigh the benefits, so there can be mixed opinions with respect to that. But more notably, really the only other contraindication to when you would think maybe I shouldn't be cooling this person is if immediately post-arrest, the person wakes up and is following commands, then potentially going ahead and cooling them could cause more harm to them than potential benefit. Obviously, the time in which this happens is pretty infrequent, but nonetheless, it can happen from time to time. So, what can happen to people after their arrests from a neurological perspective? We look at something called the cerebral performance category to be able to assess the range at which people can develop after arrest. In the best case scenario, patients can have good recovery. So good recovery is defined as return of consciousness, alertness, ability to work, ability to function and complete activities of daily living, so taking care of yourself, functioning in the world, and not needing assistance with your basic activities. In the worst case scenario, in grade 5, one could progress towards death. Death can be defined either due to loss of function of the heart and lungs, again, or can be defined secondary to complete irreversible loss of function of the brain. Others can be somewhere in between, so can have a moderate disability, severe disability, or can just end up in a permanent coma called a vegetative state. Now, nonetheless, it's important to be aware of the different types of deficits that people can have after their arrest. Now, I spoke previously about the parts of the brain that are most vulnerable to ischemia, and this, of course, correlates to what type of outcomes people can have after their arrest. So patients post-arrest can have cognitive deficits such as impaired attention, memory, and executive function. There can be difficulties with psychiatric deficits such as depression and anxiety. Patients can develop weakness due to a number of different etiologies, inclusive of the hypoxic injury itself, but also in the setting of cardiac arrest, one could have stroke due to poor blood flow to the brain or blood flow to the spine. And then additionally, there could be critical illness polyneuropathy or polymyopathy, which is where patients can have their nerves in their arms and legs be injured as a result, or their muscles be injured as a result of the protracted time period that they remain in the ICU after their cardiac arrest. Patients can also develop myoclonus, which is a type of shaking that can develop after arrest. Sometimes these patients can have these shaking episodes when they're wide awake and functional. Other times they can have depressed mental status and can have these shaking events. Another type of shaking events that can be seen post-arrest are seizures. And then lastly, some patients post-arrest can develop abnormal fluctuations in their blood pressure and heart rate called dysautonomia. Now, additionally, looking back at the prior study that I mentioned, about 50% of the patients who were in this series died. Now, why did they die? The majority of these patients died due to withdrawal of life-sustaining therapies. So this means situations in which after discussion between the family and the clinicians, the decision was made to withdraw therapeutic support in these circumstances. Now, in trials, we are liking to try and move further away from early withdrawal of life-sustaining therapies because we want to be able to give people more time to be able to demonstrate their ability to recover post-arrest, which will be addressed further in additional presentations today in terms of how to help to prevent that. In some cases, people in this series died secondary to return of or loss of cardiac circulation again, and no further compressions done at that time. And then a small percentage of patients died secondary to death by neurologic criteria, also known as brain death. So brain death occurs when an individual has complete irreversible loss of function of the entire brain, including the brain stem. In this situation, an individual is comatose, has absence of brainstem reflexes, and is unable to breathe spontaneously. Declaration of death by neurologic criteria is declared using the criteria created by the American Academy of Neurology for adults and by the American Academy of Pediatrics, Society of Critical Care Medicine, and Child Neurology Society for a declaration of brain death in pediatric patients. Now, what are risk factors for progression towards brain death after cardiac arrest? A number of studies took a look at which patients were most likely to progress towards brain death and found that factors that were associated with progression towards brain death included female sex, young age, unshockable arrest rhythm, neurologic etiology for arrest, so meaning that the patient had a big stroke or a big bleed which then led to their heart stopping, or a long arrest time, so a prolonged period of time between the time of their arrest and the return of spontaneous circulation being greater than 30 minutes, so a very protracted arrest period during which CPR is being performed. All right, and then lastly, I'd like to circle to the question of how do we prognosticate after cardiac arrest? So obviously there's a wide range of potential neurologic outcomes, so how do we help to figure out how somebody is going to recover after an arrest? There's a number of different approaches that can be taken, and it's important for this evaluation to be multifaceted. So we should utilize our clinical evaluation, we need to utilize imaging, we need to use electrographic criteria, inclusive of an EEG and somatosensory evoked potentials, and then lastly we can use biomarkers. So in terms of our clinical evaluation at the bedside after somebody's had a cardiac arrest, it's important to serially assess them to see whether or not they're performing any activity, whether or not their brain is showing any signs of function. In the ideal scenario, these assessments are being performed off of sedation. If patients are on sedation at the time of their assessment, then that sedation can limit the exam because the drugs will be in the person's system, and so you're not really assessing what's going on just with their brain, you're assessing more as to how their brain is being impacted from these drugs. Additionally, after the arrest, it can take, when somebody's been cooled, it can take some time for that person to bounce back from the cooling period. So you don't necessarily have a good exam on day 1 or day 2 after the arrest, but that doesn't mean that going forwards you're not going to see clinical improvement. Particularly if this person was on sedation at the time that they were being cooled, because that can take a little while for that sedation to come out of the person's system when they were being cooled. On our assessment, we want to look to see if we see any signs of wakefulness, assess for the ability to follow commands, assess for any brainstem reflexes, so the most primitive portion of the brain. So if you try to poke somebody in the eye, do they blink to demonstrate that their brainstem is intact and that they're showing a reflexive response to you poking them in the eye? If you're irritating the back of their throat, do they cough or gag, demonstrating again a reflexive response that you're irritating them at that point in time? Do they have any ability to move their arms and legs, either on their own or when you stimulate them? Do they pull away from you? Again, looking for either reflexive or intentional responses. And do they show any ability to respond to pain? We also use imaging to help with prognostication. So CAT scans are one type of imaging modality that we can employ. So as I mentioned earlier, in terms of after reperfusion, we worry about one concern being edema or swelling of the brain. So when we get CAT scans, we're looking to see if we see any evidence of swelling of the brain. So you can see here the brain after a noxic injury, you can see there's a lot of swelling in comparison to this normal brain here where we see a lot of nice spaces between different portions of the brain. The black areas are the nice spaces that you can see on the left side of the slide in comparison to on the right side where you just see a lot of swelling and there's loss of those spaces. An EEG is an electrographic study to look at the brain waves. We use this after cardiac arrest both to be able to assess to see if patients are having silent seizures and to be able to assist with prognostication. So being able to look at what's going on with the brain waves helps us to have an understanding of how well this person's going to recover. So thus as a result, we like to use continuous EEG, so an ongoing EEG, so we can continue to monitor the brain waves. If there's no ability to have access to ongoing EEG, then we can use routine EEGs, so just doing a 30-minute study every day or on an as-needed basis if we see something that's concerning for seizures. In terms of seizures, there can be seizures that are shaking, so events where you see actually the body shaking or jerking or abnormal blinking movements all can be suggestive of seizures. But there can also be silent seizures or non-convulsive seizures, and we can't know that these are happening unless we put an EEG on because they're silent seizures. So the EEG is very important in terms of helping us to know if there's any silent seizures. Additionally, our EEG is helpful in terms of prognostication, so it allows us to help to predict recovery post-arrest. So there's a number of different patterns that can be seen on an EEG in terms of what's going on with the brainwaves after an arrest that would be concerning to us. So you can see here in the first block here, A, this is a severely suppressed background. So this is just a very flat line. This is not showing us a lot of activity of the brainwaves. This is concerning. In sample B here, you can see that the background is pretty flat. It's still suppressed, but these findings that we see here are called periodic discharges, and these discharges are concerning to us because this demonstrates the potential for having seizures. It's not showing us any normal brain waves here. It's showing just the potential for seizures superimposed on a very slow brain. In sample C here, you can see this is called a burst suppression pattern. So everything looks very suppressed. The brain waves are very, very slow. And then you see this little area of a burst indicating that there's some activity, but nonetheless having this pattern is indicative of a poor brain. And then in the sample D here, you can see again that there's suppression and then there's periodic discharges, also of which are problematic. So performing an EEG can be helpful in order to understand better what's going on with the brain. Similarly, we can perform something called somatosensory evoked potentials, which allows us to understand electrographically whether information is being transmitted from the periphery into the brain and whether the brain is able to respond to that information. So somatosensory evoked potentials involves a provision of a stimulus in the arm, and then you look to see if you're seeing a response in the brain. And if you're seeing a response in the brain, then that's representative of the brain having intact ability to get that information. Lastly, there's a biomarker called neuron-specific enolase, which can be elevated in the setting of injury to the brain, and this can be helpful to us to have a sense as to the extent of injury to which the brain has suffered. Prognostication is very challenging, though. As you can see, you have to employ a lot of different modalities, and it's really important to delay your prognostication after the arrest to allow for the period of recovery before you make this assessment. So in summary, cardiac arrest causes injury to the brain both due to poor blood flow at the time of the arrest and after the time of reperfusion, so both at the moment of the arrest and many days later. Therapeutic hypothermia can help to prevent injury to the brain after cardiac arrest. Patients who survive cardiac arrest can have a wide range of neurologic outcomes, with the worst being brain death. Most deaths after cardiac arrest, however, are the result of withdrawal of life-sustaining therapy. So the use of additional therapies and cocktails could be helpful in order to allow more time for people to recover post-arrest. And then lastly, neuroprognostication after cardiac arrest can be confusing and challenging, and so it's important to allow for a protracted period post-arrest before prognosticating. Thank you.